our presentation on the STREAM trial, we do have QT prolongation over 500 milliseconds in about 10% of the group. But one of the things that seems odd talking to other groups is just, it's not just the correction, but the machine and the automated measurement versus manual measurement. So would you just maybe comment on what you did for the measurement and your comfort level in those measurements?
Absolutely. I mean, reading QTCs is a big challenge even today after many years of experience, but initially the clinicians had no experience of reading ECGs. So first of all, we had to teach them how to read ECGs and read the QTC, make the QTCF calculation, and we asked them not to use the machine measurement. We asked them to do the calculation themselves, and that's how we taught them to do it. And we had an MSF team that double-checked all the calculations, and I think at that time I can be pretty confident that they were well done. I think as you get more and more and more QTC measurements done, and as we found in endTB, there is quite some variation of the reading by clinicians, and this is a real challenge. And even for cardiologists, it's challenging. But yeah.
Just one minor question. I didn't notice the comment, I didn't see in your table, my eyesight is not good enough. What was the rate of HIV co-infection, and were there any challenges with changing antiretroviral therapy?
There were no HIV co-infected patients in this cohort, yeah.
Okay, thanks very much.
Thank you.
Okay, thanks, Kathy. So,
Okay, so after the science, I'm going to present something more technical, actually. How do we put in place the system that allows us to show you all those nice safety tables with the adverse events? So we made the experience of setting up a pharmacovigilance system from scratch in the frame of the endTB project. The endTB project, in case I have to remind you, is a consortium of 3 partners that includes Médecins Sans Frontières, Partners in Health, and Interactive Research and Development. It started in April 2015 with the aim of enrolling 2,600 patients in 17 countries under the new drugs. So active pharmacovigilance is one of the requirements since betaquolin and Dlm had no complete approval. So that was one of the challenges that the endTB project had to face. We want to treat so many patients, and we want to follow them the right way. So what type of pharmacovigilance system do we put in place to follow those patients as per the recommendations? So just coming back to the text, so in 2012 there was this very technical document about how to set up active pharmacovigilance from WHO. And I think the whole first part of the sentence in terms of active safety monitoring and management of patients under novel drugs, novel regimen, or MDR-TB treatment, the part of detecting early the side effects and managing them is something that the TB programs are doing well, and that is not new. The part that is more new and where we intervene with our pharmacovigilance system is more the part about the reporting. So just to mention that now we have this more practical framework from WHO that is called ADSM, Active TB Drug Safety Monitoring and Management, that covers the aspect of the detection, the management, and also the recording and the reporting of the side effects. So I'm going to develop more on the reporting. So the initial challenges that we had is that, yes, people know that there are side effects. They usually detect them quite efficiently because they do blood tests and clinical assessments frequently. They know how to treat the side effects. But where we were lacking a bit, some elements were around the reporting. So there was a lack of standard definitions. People, they say side effect, they say adverse event, severe adverse event, serious adverse events. There was a lack of consensus on the terms and the definitions. There was also a variety in the reporting systems and habits. So this was born from the endTB project, 17 countries, 15 in the beginning, or 16. So imagine over 16 countries how many differences you have in the habits locally. In some countries, it's highly regulated, and you have to fill in forms for every time your patients are having adverse event, and it's all organized by the Drug Regulatory Agency. And in some countries, there's nothing, or there's something, but it's not really put in practice. So we had a wide variety of reporting habits and culture amongst our countries. And I think the last challenge is not the least, is that there's a high volume of data that is generated by TB programs. Our patients are having lots of side effects. So it's also a matter of selecting the information that is important to be immediately reported versus the information that we can wait to have a formal analysis of a cohort, for example, like the compassionate use cohort that was presented before. So overall, all those challenges were rendering analysis and signal detection quite difficult. So to overcome that, we decided to go for a single pharmacovigilance unit for the whole project. And it went a bit further because now the pharmacovigilance unit is also covering for the MSF-sponsored clinical trials, but also for the MSF projects that are treating with the new drugs or the new regimen. And we decided on a level of coverage where the pharmacovigilance unit is going to receive immediately some subset of the whole bunch of adverse events that the patients are having. We are focusing on what we call the serious adverse events, which are the very, very severe ones, the most clinically significant ones, fatal, life-threatening, those for which you hospitalize the patients. We also receive regularly in an expedited manner drug-exposed pregnancies and medication errors, but they are fewer than the serious adverse events. So that's our mandate at the pharmacovigilance unit. Of course, the immediate objective of the pharmacovigilance unit was to ease the access of patients to the drug. I'm not going to put it better than it was, because it was perceived as a barrier as a first. You have to do active pharmacovigilance for everyone. But we don't have the means, we don't know how to do. We may not have forms, we may not have a formal system. So it was perceived as a barrier. So the immediate objective of the Central Pharmacovigilance Unit was to overcome this perceived barrier. And of course, our mid and long-term objectives, which we are starting to reach now, that we cover more and more projects and that we are enrolling more and more patients on the new drugs or new regimens, are of course to gather and analyze the safety data in order to make signal detection. So in case there is something that is happening somewhere, we are able to capitalize this information centrally and react quite quickly if something needs to be changed. So that's just a small timeline just to give you an idea of how much time it took us to reach the level of having an active pharmacovigilance system in place. So we started in April 2015 when the Unit 8 grant for endTB was signed. And the very first step that we took was to decide on common tools that we are going to use everywhere the same. I think that's the first step, to speak the same language amongst the 17 countries and more afterwards. So we decided on a single pharmacovigilance database, we decided on a single severity grading scale, so that's grade 3 hepatotoxicity in Pakistan is the same as grade 3 hepatotoxicity in Peru. So we wanted to have a harmonized tool that everyone is going to use and to use in the same way. We also defined all our processes in standard operating procedures, which is not the most thrilling part of setting up a pharmacovigilance system, but that's very useful because it allows me in Geneva to work exactly the same way than my colleagues in Boston or in Pakistan. So that was something that we had to go through. In August 2015, we were ready theoretically. Saying theoretically because I think the major step to move to something practical, to get side effects reported, and the system and the signal analysis onward was the training. That was really the key point. And the very first thing that we did was to train each other, actually, centrally, was to sit all together with the central teams and make sure that we are all aligned on the definitions, the procedures, and what we are going to tell the local doctors afterwards. So we started formally the training in the field with Georgia in October 2015, and just afterwards Armenia. It went quite well, and now we have trained like so many people, more than 100. I put on the slide from March. I think now we are around 200. And maybe another important information is that now we have an e-learning that is available. So the training is a continuous activity because there's turnover on the sites, of course, in the hospitals. But also because sometimes people, they want to get a bit reminder about what to do in this situation, because some of those situations about serious adverse events and pregnancy, it's not that often overall. So if you have been trained in 2015 and you get your first serious adverse event in 2016, you may like a little refresh. So we try to provide practical tools, and that's the whole idea of this centralized pharmacovigilance unit, is to be very practical. I'm running out of time. So that's just the flow that looks very complicated. We can come back in case there are questions, but I just want to comment a bit on what we ask the doctors to do in practice and what we are doing in practice. So the very first stage is the detection of serious adverse events or reportable information. The doctors, once they hospitalize a patient for any reason, or when there is something fatal or life-threatening happening, they fill in forms for us. And they fill in forms for us for all the adverse events, regardless of the cause. So if the patient gets hit by a car in the streets, they also report, because the patient is in the hospital, it's a serious adverse event. And so that's the first stage. And we ask them to give us their opinion on the causes of the adverse event. That's the next step. So we want a doctor that is reporting to tell us, my patient got hit by a car in the street, he was doing fine, it's just an accident. The cause is outside. And we do the same exercise in-house. So I'm getting the form, we enter the information in the database, and we analyze the information another time from our central perspective, from the perspective of all the countries that we see are reporting to us. And we do the same exercise, and we look at what happened to the patient, and we evaluate. So I told you the patient got hit by a car in the street. We ask ourselves a bit of more questions. Maybe he was dizzy, maybe he fell, maybe he fainted. So we try to investigate all the serious situations, all the situations fatal or life-threatening that are very important clinically. So this exercise is done with the help of experts. And we feed back to the teams. So we feed back to the single doctor in case we have information that is really specific for him or her. Or we feed back at the level of the endTB project, because that's something that we think in endTB we should raise awareness about. And of course, in case we detect something very, very nasty, I would say, we would report and communicate about it at a higher scale. So there are different scales of emergencies, I would say, in the information and the signals that we detect. Currently, we didn't detect anything really worrisome. We just did some communication to align a bit the processes, mostly. But the idea is to have a system that is very transparent and centralized. Maybe we'll stop there. Thank you.
Thanks very much. I'm sorry your time is up. If people want to ask Natalie questions, please can you come after the session and discuss it with her. Our next presenter is drugs beyond the registered 6 months. Is it safe and effective? Thank you very much.
So, thank you very much. It's a pleasure to present you the results of this strange French-Latvian collaboration. So this is the outline of what I'm going to present you in the next 10 minutes. So first of all, we all know the shortcomings of the current MDR-TB treatment, which is long, even its so-called short course version is still quite long. It's poorly tolerated because of pill burden, injections, adverse events. Efficacy rates are low and range from 60 to 26% in MDR and XDR strains in programmatic conditions, and it's still quite expensive. So in this framework, of course, the development of and availability of new anti-TB drugs was a major breakthrough. So bedaquiline, which was approved for the use in MDR-TB in 2012, and delamanid in 2014, they both have a completely new mechanism of action. So in this talk, of course, I will concentrate more on delamanid. This compound belongs to the nitrimidazole family, like another compound, pritomanid, which is also very promising. It has a good oral bioavailability, an half-life of around 30 hours, and phase 2b clinical trials, randomized clinical trials which have been published yet, have shown that this drug is capable of increasing culture conversion rate and is associated with reduced long-term mortality. The drug has a good safety. Yes, it is known that it increases the QT interval, but this has not been related to clinical adverse events at on the cardiovascular system. So currently, the WHO recommends to use Dlm in adults and in children of 6 years of age or more who have MDR-TB, whenever an effective treatment cannot be designed, or in case of resistance or intolerance to any fluoroquinolones or second-line injectable drugs, and in case of presence of risk factors for poor treatment outcome. The currently recommended treatment duration by WHO and manufacturers is 24 weeks. So whenever we prolong the treatment, we are going off-label. And what about the combination of the new drugs? So bedaquiline and Dlm, this is allowed by the manufacturer. It's not even contraindicated by formally contraindicated by the WHO, although the main recommendation is to use the concomitant treatment of the two drugs in patients with no other therapeutic options, and rather to use the two drugs sequentially with quite a very long washout when you're switching from bedaquiline of Dlm to Dlm 6 months because of the long half-life of bedaquiline, or to use it with a shorter washout when switching from Dlm to bedaquiline of 5 days. So far, the evidence on this combination is very, very little. We just have 3 published case reports in the literature. We report for only 5 patients and interim outcomes mainly. So the main objective of the study was to assess in particular safety and also efficacy of the use of Dlm with a particular focus on prolonged treatment for more than 24 weeks. And since we found out that quite a lot of patients in the cohort were exposed to both drugs, we wanted also to, as a secondary objective, to assess the efficacy of the combination, the safety of the combination. So this retrospective cohort study includes patients recruited in few centers in two countries, so in Riga, in the TB hospital in Riga, Latvia, and in 3 TB referral hospitals in Paris, France. So mainly this cooperation was really born since we realized that we are using drugs for MDR-TB in a similar way. We have a similar NTP with a strong TB Consilium, who works at the national level, which allows for a certain flexibility and individualized treatment, including prolonged treatment and association of the new drugs. So basically, in these centers, all consecutive MDR-TB patients will receive at least 30 days of treatment with Dlm, and who started treatment for MDR-TB until the end of October 2015 were included into the study. So these are the results. Globally, we had 30 patients included in the cohort, 20 in Latvia and 10 in France. Most of them were male and adults, with only 2 pediatric cases. HIV infection was very rare, while hepatitis C co-infection was present in 20% of the patients. And most of the patients had previously received TB treatment. All of them had pulmonary TB, with the majority of patients having bilateral involvement with cavities, and 3/4 of them approximately who had a positive smear exam at treatment start. So roughly half of the patient had XDR-TB, and half of the patient had pre-XDR-TB with resistance to fluoroquinolones, with a number of 8 drugs which were tested resistant on DST in median in the cohort. Okay, so these graphs shows the length of exposure to the new drugs in the cohort. So of course, all patients, this was the selection criteria, received Dlm. As you can see, the median duration of treatment with Dlm was almost 300 days, and more than 3/4 of the patients, this is the interquartile range, received more than 24 weeks of treatment. 24 weeks of treatment is represented here by the red bar. 11 patients received bedaquiline with a much more variable duration, although the median of these patients received as well over 400 days of treatment. And finally, we assessed the exposure of both drugs. This could be when patients were treated concomitantly or when they had sequential treatment, but without respecting the washout period. So calculating the exposure this way, the 10 patients were exposed to both drugs for a period or median of around just over 24 weeks, with a couple of patients who received both drugs concomitantly for the full treatment. So here I'm showing the other drugs which were associated to the new drugs in these individualized regimens, and I just want to draw your attention on the red columns, which represent the QT prolonging drugs. So 2/3 of the patients received fluoroquinolone, mostly moxifloxacin, and approximately 25% received clofazimine. So these are the safety results. Here you can find in dark green the results in the total cohort of 30 patients, and in light green the results in the subgroup of patients which were exposed to both new drugs. So as expected in MDR-TB treatment, almost every patient had at least one adverse event. Serious adverse events occurred in 30% of the total cohort, while no severe liver enzyme elevation was reported. QTCF increase was pretty rare, occurring in only 2 patients and in no patient who had exposure to both new drugs, while the values of more than 500 milliseconds occurred in 2 patients. Both of them were exposed to both new drugs. However, QTCF prolongation did not lead to any cardiac events and did not lead to stop any of the new drugs in this cohort. Actually, the Dlm was discontinued in only 1 patient because of adverse events. So the efficacy was really not the main objective of the cohort. Anyway, we are happy to report that more than 80% of the patients had favorable treatment outcomes, and this is consistent also in the subgroup of patients who were exposed to both new drugs. And actually, the other patients were all lost to follow-up, so there were no treatment failures in this cohort. The time to sputum culture conversion is showed here in the bottom of the page, of the slide. It was of 80 days with 3/4 of the patients who converted the cultures before 3 months of treatment. So in conclusion, the results of our very small cohort we can conclude that MDR-TB regimens in this small cohort was quite well tolerated, even if we used long-term treatment with Dlm and Bdq, and also the combination of Bdq and Dlm. So, of course, as clinicians, our heartfelt recommendations will be to use these drugs also in an extended way beyond 24 weeks. Whenever needed, also using the concomitant Bdq Dlm treatment whenever indicated for the individual patient, and in particular trying to use the concomitant rather than the sequential use, because of course sequential use is really the best way that we have to select drug resistance in infectious diseases in general. So of course whenever the criteria for eligibility are met. So of course this is a recommendation that you could say thank you very much, but this is just a 30 patient cohort, but I also recommend you to have a look at this publication, the recent publication by the WHO, which is really underlining that off-label indications for Bdq and Dlm should not be something that is completely unimaginable for us whenever the benefits outweigh the risk for the individual patients. And so I will just conclude by thanking my colleagues from the Bligny Hospital, so Mathilde Jakim, and colleagues working in this beautiful hospital in Riga, Liga Kuksha and Linda Barkane. So thank you very much for your attention.
Very interesting presentation, and I think it's allaying many of our fears that the combination is not a good thing. I understand it's a small cohort. We've got a little bit of extra time because we do have some no-shows, so are there any questions from the audience? I've got a couple of questions. Again, it relates to how you monitored QT. Who ran the ECGs, who read the ECGs, and was it validated in any way?
So here I would ask definitely Liga to explain what it's done in Latvia. So I can speak for the centers in France. So well, QT, the ECG is done, let's say, according to at least according to WHO recommendations. I think we are a little bit on the cautious side since we have a lot of means, of course, in France. So it was, I mean, we had ECGs every week probably in patients with receiving or more, receiving especially the combination of the two drugs. The reading is done, we use the QTCF interval using the manual reading. So as Kati was explaining before.
So in addition, Liga Kuksha from Latvia, our ECG is read by a cardiologist, and then when it's calculated, manually calculated QT interval, then we calculate using QR calculator in a phone app, this QTC by Frederica. That's our approach, and we usually do it once a month, not often, just for patients who have some additional factors for cardiotoxicity. We measure it much often. It means every 2 weeks. But actually in this cohort we have any patient who had QTC more than 500 milliseconds. And actually in our cumulative cohort, which is more than 90 patients, we have only 2 sporadic cases of more than 500 milliseconds QT prolongation.
Thanks very much. Very nice presentation. Thank you.
There's Jennifer Hughes from South Africa, who's going to present on adverse events over 6 months with delaminid in a programmatic setting in Khayelitsha.
Thanks. So I'm Jenny Hughes. I'm working in the MSF program in Khayelitsha in South Africa, and I'm one of those doctors who's filling in all of those forms for Natalie with our patients on delaminid. So luckily I've had a couple of speakers before me who've given you all of the background, but we all know about the trials for delaminid, which have shown that it's efficacious and well tolerated. The main adverse events that have been reported with delaminid have been mainly gastrointestinal events, nausea, vomiting, some insomnia and headaches, and less frequently the QT interval prolongation, which is what we're all worried about. Delaminid has been used fairly well in HIV-infected individuals because there is no drug-drug interaction with ART. So the WHO has issued guidance, as you've just heard, but there are very few case reports on data on adverse events in programmatic settings. And so the aim of our study was to describe to you the adverse events that we recorded over 6 months of patients receiving delaminid in a primary care setting in Khayelitsha. So Khayelitsha's setting is that it's based in the Western Cape province of South Africa with a population of nearly 500,000, between 5,000 and 6,000 TB cases per year, and around 200 cases of RIF-resistant TB diagnosed each year. We have quite a high HIV co-infection rate of around 70% or just over. And patients are managed, so clinically stable ambulatory patients are managed within a decentralized RIF-resistant TB program, which has been operating in Khayelitsha since 2008. So the program includes all 10 primary healthcare facilities, which manage patients on an ambulatory basis, as well as support from a 10-bed inpatient facility and the local district hospital. And then there's patient support at all levels within the community. So MSF in Khayelitsha support the existing staff within the existing facilities. We don't have a standalone MSF facility with MSF staff seeing patients. So the methods for our study, we first accessed delaminid through Otsuka's International Compassionate Use Program in November 2015, but then very quickly after that we were able to procure delaminid directly through MSF, through the GDF, from January 2016, and this was very strongly supported in terms of pharmacovigilance and patient eligibility by the Unitaid-funded endTB program, as you've heard. So delaminid was offered to patients basically in accordance with WHO guidance, but patients who had RIF-resistant TB where they needed an additional drug option. We always used Delamanid with at least 3, usually more, drugs which we thought was effective, including pyrazinamide. And for some cases, we needed prior approval from a variety of committees, so the International endTB Committee, local clinical advisory committees within our country, and we were working under ethics approval from the University of Cape Town and approval from the Medicines Control Council. So those patients that we needed approval for were those who were pregnant, under 18 years, or where we were using it in combination with bedaquiline. So as well as the patients being seen as usual by their normal primary care clinician, an MSF doctor, which was usually me, would review a patient at least monthly, but sometimes more. And we used the endTB pharmacovigilance guidelines to categorize all adverse events, assess seriousness, which are the categories that we all know about, so death, life-threatening, hospitalization, etc., and severity. So severity was graded from 1 to 4, with 1 being mild and 4 being life-threatening. And this was based on a combination of known grading systems as described there. So our analysis was looking at, was describing serious and non-serious adverse events for all the patients who initiated Delamanid over 13 months from November 2015. So this is the cohort. So there were a total of 58 patients. Nearly a third of them had RIF-resistant TB with fluoroquinolone resistant. So by definition, they had very limited treatment options. Often they had other adverse events which precluded or which excluded the use of other drugs such as linezolid, etc. So in that group, there were no adolescents or children, fairly high HIV infection rate. Most people were on ART, and they had a median number of 6 effective drugs to support Delamanid. A very small proportion were patients who'd had second-line drugs, but the treatment had failed and they had limited further options. And then the vast majority, 2/3 of our patients, had RIF-resistant TB, which was fluoroquinolone susceptible. The injectable was contraindicated, and they required Delamanid for a specific reason. So I haven't put in there the number of patients who are on bedaquiline as well, but over 80% of those who are fluoroquinolone resistant received bedaquiline in combination with Delamanid, but only one of the patients in the fluoroquinolone susceptible group also received bedaquiline. So of those 58 patients who we initiated on Delamanid, the majority of them had been on treatment, second-line treatment, for around 2 months before starting Delamanid. Obviously, those who where treatment had failed, they'd been on Delamanid been on second-line treatment a lot longer. So of those 58 patients, around 13 of them didn't complete the 6 months of Delamanid for various reasons, which you can see there on the right. So 3 died, 4 were lost to follow-up. Of all those who were lost to follow-up, they were all clinically stable at the time or the last time they were seen by us, before they were lost to follow-up, and only one of them was still culture positive. The 2 that you see at the bottom, they had Delamanid withdrawn because of severe adverse events or serious adverse events. Now, we didn't think that it was necessarily Delamanid related. The one patient who had it withdrawn after 5 days had this allergic reaction, which resolved on withdrawing all drugs, and then it recurred again once we introduced PZA. But we were a bit nervous about giving Delamanid again, so we just didn't. The second patient had baseline QT prolongation, received Delamanid and levofloxacin, and the QT prolongation seemed to become more severe when we introduced levo, but we decided to stop both of them. Okay, so I'm just going to talk you through this slide. This is basically looking at all of the adverse events in the categories according to the endTB pharmacovigilance guidelines. So you'll see the categories there along the bottom. A total of 285 adverse events were recorded, and that occurred among the majority of our 58 patients. So 50 of them, also 8 of them didn't have any adverse events over that 6 months. So out of 58 patients, I guess it's nearly sort of 5 adverse events per patient. Now, the vast majority of adverse events were new since starting Delamanid, but a few of them, they were patients who had adverse events at the beginning at Delamanid baseline, but they worsened by more than 1 grade in severity after starting Delamanid. So I've highlighted in bold colors the categories where there were more than 15 adverse events for each category. So you'll see the orange, so they kind of go in pairs, sorry. So the orange and gray bar goes along with the blue bar. So the orange is the new adverse events, the gray is the worsening adverse events, and then the blue bar is the number of patients who were affected by those adverse events. So you'll see overwhelmingly GI side effects were very common, followed by the musculoskeletal, so that's arthralgias and myalgias. The general disorders included insomnia, weight loss, headaches, and the cardio disorders included palpitations and QT prolongation. Okay, so this looks a little bit weird, so I'm gonna do it in phases. So basically we looked at, among all those 285 adverse events, how many were possibly related to delaminid? And we found that a third of them we considered could possibly have been caused by delaminid, but most likely a lot of them were caused by other treatment that they were taking alongside delaminid or other disorders. So the most common ones were, as we've said before, GI disorders, headaches, dizziness, and some cardiac events. And around 13% of those that we thought might be related were severe or life-threatening. And that's compared to an overall number of 9% of overall adverse events which were severe. So these possibly related adverse events occurred among around 68% of all patients. So serious adverse events, we found that 8% of all of our adverse events were considered serious, and half of them were possibly related to delaminid, in that it caused us to withdraw delaminid for a bit before introducing. As I've explained before, we didn't reintroduce delaminid in 2 of those patients. 13% of all of our serious adverse events, 3, which is 13% serious adverse events led to death, and the majority of them resolved. And these serious adverse events occurred among a third of our patients who we gave delaminid to. And then just lastly, 8% of all of our adverse events we thought were cardiac related, and only 6 of them had QT prolongation over 500. Sorry, I know I'm out of time. Last slide. The over 500 is actually QTCB. This is not the Friedericia formula. And the reason I presented it like this is because our clinicians in Kailicha make treatment decisions based on the QTC that's printed out for them on their ECG machine, which is often defaulted to QTCB. So once we started teaching them how to use the app to calculate QTCF, we found that the QT prolongation that was reported over 500 became much less. And then 2 of the QT prolongations over 500, which was QTCB, were among patients who were also on bedaquiline. And again, these cardiac-related adverse events occurred among a third of our patients on delaminid. So in conclusion, the adverse events, as we know, for anybody on drug-resistant TB treatment are very common, but less than 10% of them were considered serious. At least 3/4 of the adverse events were thought due to factors or drugs other than delaminid. So we feel that clinically stable patients on delaminid can be managed in a primary care setting, provided there's regular monitoring. And access to delaminid really is still very severely restricted, but we think could benefit countless patients globally, including people co-infected with HIV. Thanks.
Thank you, Jennifer. That's a very clear presentation. We do have time for 1 or 2 questions. People would like to ask Jennifer something about the delaminid program. South Africa. So I'll ask, I mean, what is the plan in South Africa in terms of increasing access to delaminid? I mean, South Africa has increased access to bedaquiline, but do you have a sense of how quickly it will move in terms of delaminid?
Yeah, I don't feel like it's moving as quickly for delaminid as for bedaquiline, but there is progress. So Otsuka have put in an application for registering the drug in South Africa. So, we're hoping that will be in the next 18 months or so that we get the drug available, or that it's registered so that we can use it. But in the interim, the National Department of Health is going on the back of the bedaquiline access program, which increased access to bedaquiline nationally, and trying to implement the delaminid access program. So that's with a donation of delaminid from Otsuka, which the original sites who first implemented bedaquiline are going to be starting to use delaminid as well. But progress has been quite slow, so we're hoping that will speed up over the year.
going to be talking about risk factors for developing hypothyroidism in MDR patients receiving either ethionamide and or PAS in Maputo. Hypothyroidism is a real danger and often requires A, laboratory support, and B, concomitant medications. So I'm looking forward to your talk. Thanks, Iris.
Thank you, and thank you for the opportunity to speak here. So, according to WHO, in 2015, there were around 125,000 patients that were enrolled in MDR-TB treatment worldwide. And today, probably this number is even higher. An MDR-TB regimen requires second-line drugs, for example, ethionamide, prothionamide, and para-aminosalicylic acid. And these drugs are often toxic, and they can cause different adverse events. And we were interested in thyrotoxicity or hypothyroidism, and this adverse event is important because failure to recognize it can result in patients defaulting from MDR-TB treatment. So the objectives of our studies were to answer following questions. First, how common is hypothyroidism in ethionamide and PAS treated patients? Then, which groups of patients are at the highest risk of developing hypothyroidism? And lastly, how should we adapt the schedule of patient monitoring related to hypothyroidism? In other words, how often should we monitor TSH levels in these patients? And to answer these questions, we conducted retrospective analysis of routinely collected data. And data was collected in Mozambique, Chamanculo district in capital Maputo. And data was collected between March 2011 to September 2017. And patients were undergoing standard 24 months regimen for MDR-TB, and they were giving ethionamide and or PAS. And so some were giving both. And these patients were also regularly monitored for their TSH levels. And we defined hypothyroidism as TSH levels higher or equal to 10 milliunits per liter. And we also excluded all the patients that had TSH levels equal to 10 or higher milliunits per liter at the baseline. So our study cohort consisted of 259 patients. Their median age was 32 years. Majority was male, 58%. Majority was HIV positive, 63%. We had 16% of patients that were extensively drug resistant, and almost all of them were given ethionamide, 94%, and 14% were given PAS. And median time spent in treatment was 18.7 months. So the interquartile range was between 10 to 23.5 months, because also some of the patients are still undergoing treatment. And then we wanted to detect patients that developed hypothyroidism. We detected 67 patients, which is 26% of our cohort. And median time that took to develop hypothyroidism was 4.7 months. And interquartile range was between 3.2 to 8.3 months. And we calculated the incidence rate to be 2 per 100 person months. And then the next question was, what are the risk factors for developing hypothyroidism in this cohort? To answer this, we used multivariate analysis and Cox proportional hazard model, and we adjusted for age, for baseline TSH levels, and also for the resistant pattern for XDR. So the most important risk factors that we detected was sex, and we observed that men are 2.2 times more likely to develop hypothyroidism compared to women, and also HIV status, where HIV positive patients were 2.4 times more likely to develop hypothyroidism compared to HIV negative patients. And then to illustrate this, I will show you here a graph. So on the y-axis, you can see the percent of patients that don't have hypothyroidism, and on the x-axis is time in days. So by definition, none of the patients had hypothyroidism in the beginning of the regimen, and then you can see how slowly over time patients are developing hypothyroidism, and most of them developed it in the beginning of treatment. And you can see nicely in orange, it's female patients, in blue is male patient, and you can see that there is a difference in proportion of patients of different sex that developed hypothyroidism, and this difference is significant. And then we did the same for HIV status. So again, the y-axis is the same, it's the percent of patients without hypothyroidism. X-axis is time in days, but here we are looking at HIV status, where orange are patients that are HIV negative, and green are patients that are HIV positive. So you can see that much higher proportion of HIV positive patients developed hypothyroidism over time. And again, you can again observe the same pattern, that it's in the beginning of the treatment, in first, let's say, 300 days. So what can we conclude from these results? Well, first, that hypothyroidism is in fact a common adverse event in patients that are treated for MDR-TB that use either ethionamide or para-aminosalicylic acid. And in our study, it was 26% of patients, but there were other studies that had a range between 5% to even 60% of patients. And then secondly, we detect that 1/4 of patients with hypothyroidism developed it in the first trimester of the treatment. And this is important because it means that the testing of TSH levels should be performed regularly and should be started already within 2 or 3 months of the treatment. And a specific focus should be put on HIV patients because, as I showed, they are more likely to develop hypothyroidism. And finally, we detect that men are more likely to develop hypothyroidism, but we do have an indication that it's particularly HIV positive men that are more likely to develop hypothyroidism. And with that, I would like to thank the patients, Ministry of Health of Mozambique, MSF team in Mozambique, and MSF Switzerland. And thank you for your attention, and I'll be happy to answer.
Got time for questions?
So thank you very much for the nice presentation. I was wondering, but first of all, if you, I know I'm really ignorant on the topic, if it's, has it been described before, this big difference between sexes in the rate of hypothyroidism, drug-related hypothyroidism, and second, was it a difference in the baseline level of TSH between male and female?
So there was one study that also saw men are more likely to develop hypothyroidism. I cannot remember in which country, and we did correct. I'm not sure if there was a difference between baseline TSH level between men and women, but we did correct for that in the model, so it should be taken into account.
Thank you for your presentation. You see, two important observations which I see is it occurs early in the first 3-4 months, and it occurs in almost 1/4 of the cases. So the next question which comes to the mind is, how do you manage it? What we do, I am from Delhi, India. Unless it is very severe, the hypothyroidism, we continue the drugs and we replace with Eltroxin. So how did you manage these cases?
So as far as, I'm not a clinician, but as far as I know, it's the same. So we give levothyroxine. But I think that the problem is that, and what I'm also trying to say here is that if you don't monitor, you don't detect, and then patients have side effects and they can default the treatment. So, yeah.
Thank you.
My name is Dr. Romero from South Africa. Thank you for a really beautiful presentation. I just want to ask a question about the definition. And I see that in the definition you defining hypothyroidism only by TSH levels. And I would like to know if levels of T3 or T4 were taken in consideration. Because at the end of the day, TSH is only a hypophysis-releasing hormone. So it can even be increased in patients that have an hypophysis tumor and may produce actually hyperthyroidism. So I'm not sure if T3 or T4 were taken in considerations?
This is routinely collected data, and we don't have the information of T3 or T4 hormones, so it was the only indicator of hypothyroidism that we could consider.
Actually, I had the same question, but do you have the data from those 26% patients who develop hypothyroidism? The baseline level was higher than 4 as normal, at least. And yeah.
Yeah, I'm not sure.
Yeah,
I'm not sure.
Because it makes sense because we monitor closer those patients who have elevated TSH at the baseline, and also your data is much higher than countries reported before, and only Lesotho reported more than 10% hypothyroidism. Usually it is 2 to 4% in the countries. And thank you very much for those 2-3 months, because in WHO guidelines there is recommendation to test TSH at the 6 months of the treatment, or the 6 months of treatment. Yeah, thank you.
Thank you.
Hello, my name is Marcela. I used to work in Mozambique, so I can answer a little bit some of the questions of these patients. Basically, we were monitoring only TSH because sometimes in the field it's very difficult to measure T3 and T4. They are more labeled. So the only way we have to monitor is TSH. At the beginning of the treatment, we started monitoring more frequently because before being in Mozambique, I saw in Swaziland, we didn't have TSH, and suddenly we had. So we monitored all the patients in a row, and we found that they were very frequently hypothyroidism, and some of them, they have very high levels of TSH, even up to 100, and it was more also frequent in children. So that's why we started monitoring monthly all these patients, and we realized that the hypothyroidism was more frequently. Majority of the patients were only on ethionamide. We are not receiving PAS because a standard regimen in Mozambique was not having PAS, was having ethambutol, pyrazinamide, levofloxacin, fluoroquinolone, but only ethionamide, not PAS. And even though the definition here was taken up to 10 of TSH, some of the patients were having this gray area of hypothyroidism between 6 and 10, and there were more. So for this between 6 and 10, sometimes we treat it with low dose of levothyroxine from 25 to 50 microcentigram, and they were doing well during the whole treatment. For the one that they were above 10, we treated with levothyroxine, sometimes a little bit higher dose, but majority were regulated well with doses between 50, 100, maximum 150, and they were doing well. So we thought it was very important to treat them because hypothyroidism produce depression, produce many other symptoms that really make the patients feel bad. And with the levothyroxine replacement, they were doing very well. And we continue the levothyroxine replacement up to 2 to 3 months after completing the treatment. Thank you.
Okay, thank you. Thanks very much. Just so we know how we are for time, did just no, and Chinmay from no, sorry, I was just making sure you were here. Yeah, thank you. Okay, and Chinmay is here as well. Okay, so let's move quickly then. So our next speaker is Shadrach Ngamani from South Africa, who's going to present to us on hearing loss, which is a topic of great interest.
Thank you so much. So I'm going to present to you on aminoglycoside-induced hearing loss, so a profile of HIV-positive and negative drug-resistant patients in KwaZulu-Natal, South Africa, and I'm Shadrach Ngamani. In line with the union's regulations, I hereby declare I have no interest in this presentation. Just to acknowledge a few people, the National Department of Health, Aurum Institute, Professor Lebogang Rama from the University of Cape Town and the University of Cape Town for providing ethical clearance, Equity Pharmacy, and Amity Health. So, introduction. Drug-resistant tuberculosis is a major challenge in the control of tuberculosis, which itself remains a global health problem. During the year 2015, South Africa initiated about 12,550 MDR-TB patients on treatment, which constituted about 10% of the global cohort for the same period, resulting in the 6th highest burden the sixth highest burden of tuberculosis, and the fifth highest incident of drug-resistant TB cases. In 2015, WHO reported South Africa to have one of the highest prevalences of HIV/AIDS, with 60 to 80% of our TB patients being co-infected. The regimen for MDR-TB in South Africa includes the use of second-line drugs, which are aminoglycoside and polypeptides. So the study aim is we wanted to determine whether HIV-infected patients are likely to develop a hearing loss more than HIV-negative patients who are exposed to second-line injectables. But we also wanted to report on the use of second-line injectables on the auditory functioning, and also describe the audiological profile of drug-resistant TB patients treated with aminoglycosides and polypeptides. So we selected a facility in one of our high-burden areas in KwaZulu-Natal, Doris Goodwin TB Hospital, which is a drug-resistant TB hospital in South Africa. So in KwaZulu-Natal, we have the highest burden of TB and HIV, and it reports for 1/3 of the total cases that are reported in the country for both HIV and drug-resistant TB. So the methodology that we focused on, we looked at the descriptive retrospective folder review, whereby we looked on the patient electronic database where we record all patients receiving treatment for the period of September 2015 to September 2016. And in Doris Goodwin, there were 277 patients that were registered for treatment. The inclusion criteria, we wanted to make sure that we assess patients that that are treated with aminoglycosides, but they were followed up for audiological assessment, and as well as had baseline assessment. And we wanted to exclude patients that were not treated with aminoglycoside, and we looked at 277 folders. So in terms of the indicators, these are the measurable variables that we looked into. In terms of the biological identifiers, we looked at age, gender, HIV status, ART treatment, as well as whether the patient was previously treated for tuberculosis or not. And audiological measurables, we wanted to look at the number of hearing tests the patients conducted, the date of the first threshold shift, the number of months on treatment, and after the first recorded threshold shift, as well as the type of hearing loss as a result of aminoglycoside. So these are some of the descriptors that we found. We found that 59% of our patients were male, with the median age being 35 years old, and then 56% of those patients were new TB cases, and 44% of those patients were patients that were previously treated for tuberculosis, and there were some treated with second-line injectable. The HIV status of these patients, 83% of them were HIV positive, with 17% being HIV negative. Looking at the drugs in terms of the second-line injectables, 94% of them were treated with kanamycin, and 4% were treated with amikacin, and only 2% were treated with the polypeptide, which is the capromycin we use in the country. Now, looking at the audiological profile, we know that we see that in terms of the number of hearing tests conducted, each patient, 41% of the patient had 2 tests that were conducted, and up to 33% had 5 tests that were conducted, so they were monitored throughout the injectable phase. And in terms of the follow-up tests, about 50% of our patients were followed up to 2 times, and 49% were followed up between 3 and 5 times. Only 7% of the patients had only a baseline assessment, and the rest had a baseline and a follow-up assessment, which in our guidelines we recommend that when a patient is on injectables, before we initiate treatment, we do a baseline assessment, and then they are followed up on a monthly basis whilst on injectables. Now, in defining hearing loss, we looked at the WHO grades of hearing impairment, which looks at slight, moderate, severe, and profound hearing loss. And for ototoxicity threshold detection, we looked at the American Speech and Hearing Association significant change in criteria for ototoxicity, which talks about threshold changes in the audiogram. Now, our key findings, we found that 82% of the HIV-positive patients had developed a laryngogenic hearing loss as a result of second-line injectables, and only 17% of the HIV-negative patients had developed an ototoxic threshold shift. And in the whole study group, 94% of the patients had developed an ototoxic threshold shift relative to their previous hearing assessment. Okay. What we noted is that 75% of the patients that we looked into, they had developed a threshold shift within 30 days of being on treatment, and 12% of them had developed a threshold shift between 31 and 60 days. What was an interesting discovery is that in terms of the threshold shift, we noticed that within 14 days of being exposed to aminoglycoside, patients had a threshold shift that occurred within 14 days. And we found this threshold shift in this particular age group. The median was 14 days in this age group. The prevalence in terms of the ear, where we saw the threshold shift, we saw that in the right ear, we saw that toxicity occurred more in the right ear than in the left ear. There was no significant correlation between the age and the date of threshold shift in our analysis. Looking at the trends analysis, looking at the trend line, we saw that in terms of the trends analysis, that over time, the patients that were exposed to second-line injectables developed a hearing loss, and it progressed rapidly. And noticeably at the frequency 8,000, 5,000, and 3,000, we saw that there was a huge decrease in hearing at these frequencies. So, to conclude, the use of IPT we know that aminoglycosides do cause a hearing loss. So, in conclusion, the use of IPT as a standard measure of care in our HIV-positive patients will aid in the reduction of active TB or drug-resistant TB transmission in our communities, thereby decreasing the incidence of TB and drug-resistant TB. But moreover, we need effective ototoxicity screening and monitoring program for all our patients that have been exposed to aminoglycoside, that before starting treatment, we need to understand what is the audiological profile of these patients, so that if there's a pre-existing hearing loss, that these patients are excluded from the normal conventional treatment that includes injectables, and they are scaled up to new agents, right? But throughout the injectable phase, we need to be monitoring these patients to see if there's any changes in threshold. And once the thresholds have been detected, that the treatment needs to be stopped, injectables needs to be stopped, and patients scaled up for bedaquiline. Patients suspected of possible hearing deficit, the use of aminoglycosides or polypeptide therapy should be discontinued, and patients should be scaled up for new or repurposed agents. Thank you.
I'm going to take one question. Okay, we're going to take two because I can't say no. But if you, again, introduce yourself, go from there. Thanks.
Okay. Thanks. I'm Richard Court, University of Cape Town. Thank you, Shadrach. That was an excellent presentation. Got two questions. One, were any patients tested at high frequency, so above 8,000 kilohertz? And secondly, in the patients that had TB before, how many of them were treated with kanamycin or amikacin in previous episodes?
Can you repeat that? I'm struggling to hear.
Okay. Sorry, were there any patients tested at high frequency, so above 8,000 kilohertz? And secondly, in the patients that were treated with TB previously, how many of those were MDR, and how many of them were treated with kanamycin?
Okay. For all the patients were tested on high-frequency audiometry, portable high-frequency audiometry.
Okay.
We didn't include the high frequencies to analyze that because there is no numerative data for that.
Okay.
So we looked at the octave and where the changes occurred in the octave. Although threshold changes were noticed in the extended high frequencies, we deliberately omitted that because those are volatile frequencies, and we didn't just want to use the ASHA criteria for that, because the part of the the aim was to also explain the audiological profile, but we did mention in terms of there was a threshold shift in that. So with regards to your second question in terms of how many were treated for that, we didn't record in terms of that. We noticed that they were previously treated because these are the information that we got of the EDR web.
Thank you very much for your presentation. It's really informative. I'm a nurse practitioner, and actually, I'm doing some study about the toxicity as part of my PhD dissertation. So it's really wonderful. Actually, I have more than 10 questions, but let me just ask you one of them, because a lot of patients are receiving the kanamycin as a for the MDR-TB treatment, because kanamycin is dose dependent and weight based. So did you see any patterns or any interesting relationship between the baseline dosage or frequency of the medication on the hearing loss, or or timing of the hearing loss, or did you see any patterns of their baseline body weight related to the incidence of the hearing loss? Thank you.
In part of our data collection, we didn't look at the weight factor in terms of the drug. So this was more of like a snapshot in terms of the hearing profile of the patients. But it's a good thing. I think it's for future research, we'll look into that in terms of the changes.
Okay, thank you very much.
Okay.
I'm sure people...
Thank you.
Oh, sorry, go ahead.
Okay, can I go ahead? Okay, I'm Bertrand from Nigeria, CDC. It's actually known that HIV infection in itself is associated with hearing loss. And there are still ongoing studies looking at the effect of some antiretroviral on hearing loss. I wanted to know how you're able to factor this background information in your analysis.
Well, in the studies that we looked into in terms of ototoxicity with ART medication, most of the studies that we looked at the South African studies. In terms of ototoxicity, only middle ear was indicated in those studies and not really an effect on the outer hair cell on cochlear functioning. So that's why in terms of, we didn't look at cumulative dosage with this study, because we know that it only affects middle ear and over time, middle ear will result in a conductive hearing loss, which, looking at the audiograms of all of these patients, there was no conductive hearing loss reported in these study group.
Okay.
Yeah, I'm Dr. Dunga from ATB Teaching Hospital in Nigeria. I've been managing MDR-TB patients for quite some time now. My question is, what did you do when you noticed there was a change in threshold of the hearing of this patient? Did you consider switching this patient to capromycin? Because from my experience, adequate hydration, optimizing the blood volume, and then early switch from kanamycin to capromycin has proved to be very beneficial to the patient in terms of halting the progression of the ototoxicity.
All right, so with this study group, we looked at the period 2015 to 2016. So the intervention when hearing thresholds are detected in these patients, what they did is they reduced the frequency as well as the dosage in terms of kanamycin. They didn't change the drug to capromycin, but now in our national guidelines, when a threshold has been detected, we stop the use of kanamycin and we immediately scale the patients up for bedaquiline. But in that period, only changes in dosage as well as frequency were the only methods that were applied in terms of intervention.
Okay, thank you very much again. Lots of interest in that topic. Thank you. To our Nigerian colleague, now is the time to come. Johanna Kambai, who's presenting on underreporting of adverse drug reactions in Nigeria. Thank you.
There we go.
All right. All right. I want to thank the union for giving me this opportunity to stand here and present our work. But first, I will want to acknowledge the presence of Professor Anthony Harris, who is here in our midst. The work that I am presenting, actually, the glory and the honor must go to him because we were trained about 4 years ago in Luxembourg, and we have used that training to do this work. There are a lot of Nigerians here. We have the director of the program, TB program in Nigeria. She is here in our midst, and I really want to acknowledge them. Now, I am presenting a model of training of how to report adverse drug reactions in public health programs. And we are only using the case of Nigeria for that model. So, why are we interested in reporting adverse drug reactions? Those that have spoken before me, from their presentation, is very, very clear that adverse drug reactions are dangerous. They can harm, they can kill. In my mind, adverse drug reactions are actually terrorists. That is the way I see them. And the best way to handle a terrorist is actually to report him or to report her to the security agencies. You don't keep terrorists in your midst, and as long as you do that, the society can never be safe. So, how do we report the terrorists in our midst? That is the model that we have developed. And so our purpose actually is to improve the quality of reporting as well as the accuracy of reporting of adverse drug reactions. And of course, we did this work because we are funded by the TDR, which is an arm of the World Health Organization. Now, what is the magnitude of underreporting of adverse drug reactions? Globally, underreporting is a very serious problem. But in the case of Nigeria, because we are using Nigeria as our basis, but if you look at the standard of adequate reporting by the World Health says that for a million population, at least there should be 200 reports annually. So if you have a population of 170 million people like Nigeria, it means that at least you should report 34,000 reports should be sent to the regulatory agency. But what we have there, as you can see, this report is from our NAFDAC, that in 2015, Nigeria has the highest number of health workforce, almost 3 million health workers. What they could report is only about 1,300 reports. So if you look at that very well, if you compare that with the standard that World Health has set, you will know that we are facing a crisis. And this is not only Nigeria, that is exactly the problem you find in other countries. Now, doctors are treating the patients and they are treating the adverse event. But the fact is that nobody is reporting the events. We record them in books and the forms are there, but there is no report. And that makes it very, very difficult to regulate. So, what did we do? Nigeria has a very robust system, and we are among the 74 countries that are actually committed to drug safety. So we have the National Pharmacovigilance Center in Abuja, and then you have the 6 zonal centers in each of the 6 geopolitical zones. So all these centers are supposed to send their report to the central office in Abuja, which is the National Pharmacovigilance Center. So this is what we have, but unfortunately there are issues. Now, so in our training, we selected our participants from the 6 geopolitical regions. We actually cover the whole countries. Each region we have representatives to be trained. Then the next thing we did, we applied the SOTI model of training. I've mentioned the SOTI course, and perhaps some of you that are in this room, you have actually participated in that. So we adopted the SOTI method of training. We applied it to get what I call the SPATI course, the SPATI model. And what we did was that we combined 6 independent activities to be able to develop the model. So the first thing is that there is a training workshop where the participants were trained for at least 6 days, and they were trained by experts in the field. And then secondly, you have the participants were mobilized. They were really supported with the resources to do the work. And then we monitored their performance for about 9 months. As they were completing the forms and they were sending the forms, we were giving them feedback so that they knew exactly what they were doing. And then secondly, we established a reporting system. Actually, NAFDAC has a physical system for reporting the events, but we discovered that that system was not very, very effective. So we introduced a system that is online, which makes it very easy. Then, of course, there was effective leadership. And then finally, we collaborated with the government. So these are the 6 activities that we combined in our own model. Now, this is the result. So you would see from that, we trained only 55 participants, and those 55 participants went and trained about 2,000. I cannot see from this place, but they trained about 2,000 facility-based staff within 7 months. Then also, when we look at the knowledge gain, the time we train them, we assess their knowledge before the training. And after the training, we assess the knowledge again. There was a significant difference between the mean pre and the post score, so suggesting that there was actually an increase in knowledge. In 7 months, they were able to submit about 3,000 reports. If adverse events are terrorists, they reported 3,000 terrorists within 7 months. To us, that is a significant achievement. And if we compare that with what was submitted by from the general population that are not trained, there was a difference of about 273%. Suggesting that our model, if it is used, it is capable of increasing the reporting of adverse events by 273%. Now, these are some of the events. There were so many events that our participants were able to identify, which people never knew. These are cases of Stevens-Johnson syndrome from people that were taking nevirapine. Okay? Now that is efavirenz. Now, by the way, these are not ladies, they are men. Now, these are men that took efavirenz for quite some time, and this is what happened. Now, this is very, very serious because one of those men that you see there, he's on, in fact, at the time we collected this data, his wife has already left him. He has lost his own family. And the greatest gift God has given you is your own family. When you lose your family, you are down to nothing. He lost his own family. The other person, the family has to keep relocating from one village to another village. They withdrew, the boy was actually in school. They removed him. So they keep moving from one village to another village because of the breast. So these are some of the things that are affecting our patients that are causing them to drop out of treatment. Now, our model was accepted by the government. You can see that is the official letter that we wrote to our own institution to formally accept the model for the training of healthcare workers in Nigeria. In fact, before we left, NAFDAC has trained about 600 staff, healthcare workers from 10 states using this model. We think that, so it means therefore that actually this model can be used in other settings because NAFDAC has proved that. So what is the lesson learned? The greatest lesson we have learned is this. that if you are going to conduct training to produce result, you must never use one activity. Don't just call people and give them capacity and after that and allow them to go and expect to achieve result. You won't see anything. But when you combine other activities to the training, you are likely going to see result. We succeeded because we did not just rely on the workshop. There were other things that we did and we were able to achieve these results. This is the lesson learned. I want to acknowledge World Health for giving us the grant. Of course, I want to also acknowledge the Institute of Human Virology and of course, even SOTI, that has actually trained us and given us the capacity to do this work. Thank you.
I'm sorry, we're running short of time. We won't be able to have questions. I'm sorry about that. But thanks very much for your presentation. Our final presentation is from Chin May, who works in India and is going to discuss the impact that it has on the treatment of drug-resistant TB. Thanks very much.
Thank you, Jess, and good morning, everyone. I will try to follow the energy that Johan had introduced into this room. So I'll be presenting today about the psychiatric comorbidities among the drug-resistant patients that we treat in Mumbai, India. Just a brief introduction. So India has about a quarter of, one-fourth of TB patients among the world and one-fourth of MDR-TB patients. And Mumbai, which is a city of about 21 million people, has disproportionately high burden of especially TB and drug-resistant TB in the country. We all know what are the different side effects or the adverse events of MDR-TB treatment, so I won't go into that. And also about the psychiatric adverse events, we know that it can be due to treatment and due to drugs in the treatment, many different reasons. So again, I won't go into those details. What I would like to point out here is that most studies that have been done on psychiatric comorbidities have been focusing on depression mainly and a few on anxiety. And there have been very few cohort studies that have been done in MDR-TB patients looking at psychiatric comorbidities during the course of treatment. So the objective of our study was to determine the burden of psychiatric patients among MDR-TB patients enrolled at MSF Mumbai, and also to look at factors associated with psychiatric comorbidity. So this is a retrospective cohort analysis using routinely collected clinical data, and the study setting is MSF's HIV and MDR-TB clinic in Mumbai. To tell you in brief about what we do in Mumbai, so we have a private MSF clinic where we treat third-line HIV patients only. We don't take first and second-line HIV. And we do MDR-TB where we have an inclusion criteria currently of having only pre-XDR and XDR-TB cases. So we do not deal with DS-TB or MDR-TB. Our inclusion criteria is pre-XDR and XDR. Also, we have, along with the team of doctors and nurses, we also have a patient support team of counselors, psychologists, then we have social workers, we have a MDR-TB peer who work with the patients, and also a psychiatrist who visits. So about the psychiatric component that we have, so all the patients, once they come to the clinic, a baseline psychiatric assessment is done by the counselor, and during each follow-up visit, the patients meet a counselor who do counseling along with the tests to look at their psychological mental health condition in general. In case the counselor suspects or that the patient needs more attention, it's going out of his hand, then the counselor refers the patient to an in-house psychologist who takes over and he evaluates the patient further. If the psychologist again feels that no, this is again out of my hand, the patient needs some kind of pharmacological intervention or some specialized care, then the psychologist refers the patient to a psychiatrist. The psychiatrist currently visits about 5 times a month to the clinic, and patients are lined up according to their need during his visits. The clinic doctors can also directly refer the patients to a psychiatric via the psychologist. The psychiatrist then evaluates the patient, and we have a special section in the patient file wherein all the notes related to the psychiatric comorbidities are entered. If necessary, the patients are initiated on pharmacological therapy, and depending on the condition of the patient, follow-ups with the psychiatrist, which can be weekly, once in 2 weeks or once in a month, are followed till the end of the pharmacological treatment as decided by the psychiatrist is done. For the patients who do not, the psychiatrist feels that they do not need any kind of pharmacological intervention, some other things such as one-on-one counseling or support groups or meeting with DRTB peer, etc. is done for those patients. Methods, so we have included all patients who had initiated DRTB treatment from Jan 2012 to December 2016 at our clinic in this analysis. And we have collected the psychiatric comorbidity data from patient files. To give you a brief idea, we had 226 patients who were enrolled with a median age of 28. Half of them approximately were females, and 40% were HIV seropositive. And if we look at the TB resistance pattern, 75% of our cohort during this period was either pre-XDR or XDR-TB. To look at the cascade of the psychiatric care that we had. So all the patients were seen by a counselor, and 123, that's about, excuse me, 123 were referred to a psychologist. Out of those 123, 69 were referred by the psychologist to a psychiatrist, and 55, that's about 24% of the entire cohort was initiated on pharmacological interventions by the psychiatrist. To look at the different spectrum of disorders, so we have grouped them according to the criteria here. So about half of them had depressive disorders, a quarter of them had anxiety disorders, 15% had psychosis, and 5 other patients had some other conditions. So we had very few, just 4 patients had drug-related psychiatric adverse events, which was mainly cycloserine-associated psychosis. And the median time to referral was 3.5 months from initiation of treatment for depressive disorders and 4.3 months from initiation of treatment for anxiety disorders. Also, we found that HIV status was not significantly associated with psychiatric comorbidity. Also, we found that with the model that we are using of continuous care, having a psychiatric comorbidity was not seen to affect the DRTB outcome in our cohort. Also, no patient had to stop DRTB treatment due to any psychiatric comorbidity. Some drugs were stopped, like for example cycloserine, but no one had to stop it altogether due to any kind of psychiatric comorbidity. So to sum up, the burden of psychiatric comorbidity was very high in our cohort of DRTB patients. At about 1/4 of the patients needing psychiatric help. Depression was the most common comorbidity that we found, and we also found that psychiatric comorbidity conditions did not interfere with completion of anti-tuberculosis treatment. And to conclude, systematic screening, early identification and proper management of mental health conditions can assist in successful DRTB completion of DRTB treatment, and a comprehensive mental health component, including access to specialized psychiatric care, should be integrated into all programs caring for DRTB patients everywhere. So I'd like to acknowledge our patients and all my colleagues, my Mumbai and MSF colleagues everywhere. Thank you.
Very much for that presentation. I think it really brings to the fore that we're looking after patients who come with a miscellany of conditions. We've got time for one quick question, if anyone wants to ask a question with regards to this presentation. I've got not so much a question as an observation that even though there's a high level of psychiatric comorbidity, it doesn't really impact on outcomes. But it's difficult to pick out the fact that you picked them out. You found the patients with the psychiatric comorbidities and you managed them correctly. Of course, it's unethical to not do that, but it would be interesting to see in a poorly functioning healthcare system, if they're not found, does that impact on outcomes? Thank you very much.
So thank you everyone for staying, and second year in a row I've mismanaged time during the session, so if you put in your evaluation forms that I should not be a chair for next year, I would appreciate that. But thank you for sticking it out, and we hope you enjoy the rest of your day.